So welcome international faculty. We have on board today Miss Mary Claire, and she is from Chelsea, Westminster and Cromwell Hospital, London, UK. She is a renowned for pediatricology. We also have the honor to have Dr. Anju Goyal from Royal Manchester Children's Hospital, again prominent pediatricology from UK. And we have eminent pediatricology, and he is currently the president of European Society of Pediatricology, Dr. Sardar Tekgul, and he is the chair and in pediatricology in Hacettepe University, Turkey. So we are having national experts. Also, we have along with our chairman of pediatric section, Professor Amilal Bhatt, and we have Dr. Anil Takwani, national experts, Dr. Prasanna Venkatesh, Dr. Rahul Kapoor, and Dr. Priyanka Yadav, along with Dr. Chandra Singh and Dr. Malika Arjun Reddy also. So may I request Dr. Amilal Bhatt to have few words for all of us, and then we can start the meeting.
Good evening, everybody. I'm thankful to Dr. Sardar, Dr. Anju, and Miss Mary for joining this meeting. I hope this round session goes every year, and this time also will go with full swing. Rather than taking much time, I'll ask Dr. Ansari to start the round now.
Okay. So Ashish, are you taking? So our resident, Dr. Ashish, you first yourself, please, to Dr. Sardar, Dr. Mary, and Dr. Anju.
Good evening, sir. Good evening, sir. Good evening, ma'am. I'm a third-year resident at Sanjay Gandhi Postgraduate Institute, working under Professor Dr. M.S. Ansari, sir.
So, are you ready, Ashish?
Yes, sir.
So this is the story of a lady. She was a 20-year-old primary gravida, and she presented to you on OPD clinic with her antenatal ultrasonography, which was done at 24 weeks. That showed hydronephrosis, grade 2 on the left sided, and bladder was partially distended. So she was advised to get ultrasonography because this was only a one-sided hydronephrosis, that only of grade 2. She was advised to report back after 7 days. With 7 days, baby was born, and she came with the second ultrasonography report of the baby. This is hydronephrosis, SFU grade 1, the same. Bladder was partially distended, and the ultrasonographologist also reported that the left ureter is also dilated. So you carefully see all these images, Ashish?
Yes, sir. So the above one is antenatal images, sir.
Yes.
This we have the single image, sir. We don't have any other image, right?
So these are the images most relevant. Others was not very representative, so we did not include.
So in the antenatal period, after 24 weeks, in the mid, she didn't have any other ultrasound. She came to us with immediately the next ultrasound which was done at a postnatal period, and it was showing as an SFU grade 2 hydronephrosis with left ureter being dilated. The bladder was partially distended. So in the below images, sir, we can appreciate that the distension is of the pelvis and the major calyx, and the bladder looks partly distended, and the walls looks to be fine. There is no wall thickening, and there is a left-sided ureter is found to be dilated. So what was the gender of the baby which was born, sir, male or female, sir?
I give you further information about this. It was a female baby born, and other findings as to save the time. Local examination, genitalia were normal. There was no bladder lump, and spine was also normal.
Okay, sir. So it is SFU grade 2 with a dilated left-sided ureter, sir. So we would like to further investigate this child with voiding cystourethrogram, sir.
But I will ask Dr. Sardar, will you ask some more about this? If the lady comes with antenatal hydronephrosis with one sonology report.
Yeah, this is a prenatally diagnosed case, and there are no symptoms, but we know that there's hydro with ureteric dilatation. There's a high chance that this patient will have reflux. I mean, the chance in a normal baby with hydronephrosis without any major symptoms, the chance of having reflux is about 20%, a little more than 20. The meta-analysis says actually 22%. Knowing that in mind, you may need to look for reflux. Depending on your healthcare system, your medical legal issues and everything, you may consider doing VCUG. That's what we do at home here. But knowing that this patient may have a high risk of reflux, informing the patients about the chances of reflux and just follow the patient for symptoms could be another option as well. It's a matter to be decided by you and by the parents, knowing the risks and knowing the probability of reflux and the chances of having symptoms. This is considered to be not a very high grade reflux because there are no huge calicial dilatations, just SFU grade 2. I would assume that this would be a low grade reflux, and the chances of low grade reflux having breakthrough infections is about 15%. So, I mean, you can just follow the patient for symptoms or do VCUG and put the patient on antibiotic prophylaxis. You have to make your decision based on the risks and the healthcare system and how the parents react to your discussion points.
Right. Dr. Mary?
Yeah, I disagree with, sorry, I do agree with what I said. The only thing I'd make a note of is that there's no correlation. All the studies have shown no correlation between your extent or degree of hydronephrosis and the grade of reflux. So you could actually have high-grade reflux and a normal non-dilated kidney or a kidney like this with low-grade reflux, as we've heard. So in this situation, I would probably recommend a cystogram. She's female. In the Western world, most parents don't want to keep them on prophylaxis without knowing a diagnosis, so they may want a cystogram just to decide one way or another whether they need prophylaxis. But the presence of a dilated ureter with a significant hydronephrosis probably demands for one.
Thank you. Dr. Anju, you want to add?
No, I agree with what Marie-Claire said, and I would do an ABCUG just to grade the reflux, I think.
So, Dr. Chandra, in Indian circumstances, would you advise something different?
Actually, I wouldn't do anything different. The challenge is most of them in our scenario present with an episode of UTI. So, they but this scenario, because they are well read and they don't want radiation exposure anyway low grade, then maybe we can carefully follow up that baby.
Okay. Dr. Takwani?
Yeah, thank you, Dr. I'm a bit different in now my practice for this kind of a cases. I am agreeing with Dr. Tekbul's second opinion that as this child is not symptomatic, it's not come to us because of febrile UTI or UTI. It is just a antenatal diagnosis. And the reflux grade is not correlated with the amount of dilatation, as rightly said by the another expert. And in that circumstances, I would like to put the patient on antibiotic prophylaxis without having an exact diagnosis of reflux, but presuming there is a possibility of reflux. And then watch this patient, call the patients for another sonography, for example, at the 1 month or 6 weeks, and then subsequently another sonography if the child is doing well. Then maybe I probably either avoid MCUG or I try to delay as much as possible, because I see that many of the time there are problems with the very early VCUG. And second thing, in era where we are discussing the role of antibiotic prophylaxis, even in a proven cases,
So
what
that
is the sense
will
as
come,
such
Dr.
of
Takwani,
picking up
that
the-
will come for the management.
No, what is the
subsequently.
sense of picking up the reflux at this age, within the first 7-10 days of the life?
Okay.
Thank you, sir.
So Ashish, what should be the timing of repeating ultrasonography postnatally? What is the ideal time? Can we do it on day 1?
No, sir, actually the first ultrasound should be done after at least 48 to 72 hours. As per ESPU guideline, they have mentioned a timeline of 7 weeks, sir. And the reason what they have given is that in the initial phase of the life, there is a intravascular volume distribution, because of which there is an oliguria. So to avoid that, they consider doing it at 7 days postnatally.
So, Dr. Egul, will you agree with this? How early we can do the ultrasonography postnatally?
Well, there's no point in doing it right after birth in the first 1 or 2 days. You need to wait some time. This could be at least like 2-3 days. We like to do it like a week later. And what is really important is to be able to do the ultrasound in both states, when the bladder is full and empty, so that you can make a assumption of the presence of reflux. If the ureteric dilatation is not there when the bladder is empty, and it's there when the bladder is full, that could be an indirect sign of having reflux. So I think delaying a couple of days is the right way.
Yes. So, Dr. Mary, if had this baby bilateral hydronephrosis, then your approach will change then? In cases of bilateral?
If there's a bilateral hydroureteronephrosis,
yes,
no,
yes.
no, I wouldn't change. No.
You will wait for 7 days again.
Oh, you mean for an ultrasound?
Yes, yes.
Okay, that's a completely different scenario, which I think you're going to go through in the next one. Yeah, no, with bilateral, then we'd get it sooner, especially if
Sooner,
it's
yes.
yeah.
So it is because it is a unilateral or one-sided, then we can delay for by week. Okay. So, Dr. Anju, any thought to it?
Yeah, I agree.
Okay.
Yeah.
So these are the recommendations for the ESPU, because many of these postgraduates and the fellows, they will also be participating. So they may go through it. So what is the next investigation, Ashish, you would like to order?
So since we are planning voiding cystourethrogram, prior to it, we have to rule out any urinary infection. So what I will be ordering is a urine routine and culture, sir.
So let us see. So these are the urine analysis and the culture.
So the urine analysis is not showing any positive WBC count, and the culture is sterile, then we can go for voiding cystourethrogram, sir.
Voiding cystourethrogram. So
Sir, can I ask how you read the
So what are the recommendations for voiding cystourethrogram? How early it can be done?
So it can be done once, suppose we have ruled out any infection, we can do straightforward, sir. And there are specific indication as per AUA and ESPU. As per ESPU, if we are anticipating the high grade of hydronephrosis like SFU grade 3 or 4, or we are expecting a hydronephrosis, or we are expecting that there is a hydronephrosis, or we are expecting to have a duplex system with ureterocele. These are the few conditions where we have to do it earlier, sir. Or if there is a symptomatic UTI, once the UTI, febrile UTI have settled, sir, and we have got a sterile culture, then we can repeat it at an interval of like 4 to 6 weeks.
Okay. So, Dr. Egul, will you recommend in cases of isolated one-sided hydronephrosis to go for VCUG early, or you can just wait for another 6 weeks or so?
Well, as I told you before, I don't see any good reason why we do VCG that early. If we are aware of the fact that the child may have reflux and the child is under our control or close vicinity to our hospital, we would tell the parents as soon as they become symptomatic, they should come and see us. And we can do the VCG depending on the appointment and the availability in the hospital. We would not really we will not try to rush to have a VCG unless there are some bladder issues, thickened wall bladder, and in a boy, there's a chance of valve obstruction, then you may consider doing it early. But otherwise, we do it on a timely basis, which will take around a month or so.
Dr. Bhatt?
There are 2-3 issues which I wanted to make. I think if we have done a good ultrasound, and as Sardar has told well, that the VCUs, this ultrasound done with a full bladder and with the empty bladder, and you find that it's a reflux and SFU grade 2, I think we should wait at least for 3 months.
Yes.
In between this, tell the parents that if there is some symptomatology, then you can go ahead and do. Otherwise, no too early. The indications of VCUG early are only, as Sardar has already told, that there is some lower tract obstruction. It's a female child, it is not suspected. Or there are changes in the bladder which shows that there is, and third thing is if there is an infection, then that should be.
So, Dr. Mallikarjun, you are practicing in remote part also sometimes. So, what will be your approach?
No, I think let's all realize that reflux doesn't kill any child. So there is really no big reason for us to really rush on doing a VCUG. But if I feel that the child would not, it would not be easy for the child to come for a regular follow-up, I would err on the side of instituting antibiotic prophylaxis and then ask them to come a little later, sometime maybe around 3 to 6 months for me to have a relook. Until unless they have some symptomatology, and then they would be requested to come at the earliest. So if you are going to a corner places, then this is how I look at. If they are in a say a place where they are very near to our place, I think I am going to defer the VCUG. I don't think even if you let us assume that you have a grade 4, grade 5 reflux, things are all doing well. I don't think we are going to operate on a neonate.
So there are some specific conditions where we can go for early VCUG. Otherwise, there is no problem in holding for some more time. Yes. So, Ashish, this is the VCUG.
Sir, the voiding, so this is the single film we have, sir. Single static film. It is done in the voiding phase, right, sir?
Yes. Only we are having one representative film, this somehow.
Okay, sir.
Mhm.
So the bony landmarks appears to be normal, sir. The bladders appears to be well distended, and there is no circulation or this diverticular scene. And on the left side, we are seeing, sir, contrast refluxing up till the pelvis, and the the papillary projections are well appreciated. So I think so. It's grade 2 reflux.
So what next?
Dr. Ansari, may I make a
Yes.
comment?
Yes.
This kidney, the refluxing, does not look like a very normal kidney. It looks like a bit atrophic to me. It doesn't really go well with the ultrasound that you showed to us. It's close to the midline. The axis is lost a little bit. It's like parallel to the midline. And I feel that this is like a very small kidney.
Yeah, I fully agree, because yes, it is looking some changes, some dysplastic changes in that kidney.
Yeah.
Yes. Yeah, correct.
And also there is something around the bladder neck. Do you have any idea what it is?
But because
Sort of a feeling defect, a
But-
very
yes,
blurry.
in some of the kids, in female, we get this type of this posterior urethral dilatation, but we do not find any specific region in it. Although the mothers did not complain of any staining during micturition or
Okay.
during passing stool also.
And also one thing about the bladder capacity, if the bladder is extending beyond the bony pelvis, that is a sign that the bladder is a bit too big. And
Yes.
this could be an indirect sign of infantile voiding dysfunction. They have big bladders and they have some emptying problems from time to time.
Correct.
Can I ask
Yes,
a
Dr.
quick
Mary,
question?
yes. Yes.
What did your radiologist grade it as?
Grade of the reflux.
I'm just wondering what the radiologist thought. Because I mean, I agree, it looks like a 2, but it's quite a tortuous kind of ureter. I'm wondering if there's some dilatation,
So
whether it's more of a
you
3. But I'm wondering, because it kind of makes a difference what we do next. For me, it makes a difference what we
Yes.
do next, if it's a 2 or a 3.
yes.
But I was wondering what your radiologists thought.
Yes, they were also, they usually write, when there's not clear, they write 2 by 3. Yes, yes. Dr. Anju, do you face such problem also when they write 2 by 3? Yeah.
That's true. That's true. 2 by 3, 4 and grade 4 to 5 reflux. Yes.
Yes, they quite often they write this.
I'm not sure if there's a big difference between grade 2 and 3.
3 clinically, yes.
Actually, we would like to say low grade and high grade. If it's 4 or 5, we say high or dilating reflux. If not, we say low grade reflux. So I would consider this as a low grade reflux.
So Ashish, you have VCUG, you have sonographic, you have clinical presentation. What more do you want now before we go for the treatment part?
So as per the institutional protocol, we get a DMSA done in all those cases. Though it's a low-grade reflux, most of the guidelines refuse. They say you need not to do a DMSA scan in these children. But as an institute protocol, we take that advantage of doing a DMSA scan at this stage.
You want a DMSA scan?
Dr. Ansari,
Yes.
can I have a point, sir?
Yes, please.
Dr. Ansari. Yeah. So this was my point that doing VCUG or rush for the VCUG, sometime in this kind of a cases, we picked up the low grade reflux, and then we have to follow the consequences of this. Even the parents have to follow the anxiety and further radiological, further investigations which involves the radiations. So if the patient is in our close follow-up, then these kind of a patients can be followed without hurrying for the VCUG. Because once if there is a VCUG, there is a reflux, there is a tendency to do DMSA scan, whatever grade of the reflux is there. So this is one of my reason for not going so quickly for the VCUG in a prenatally detected hydronephrosis.
Yeah, and I would agree with that. I mean, I would agree with that even if you diagnose the low grade, that I probably wouldn't go down any further investigation. But it's true. That's what we do once we investigate, right? You've got the ball rolling.
Dr. Anju, will you agree with this?
I kind of disagree because, see, now we know that we are talking about VUR. But otherwise, if you have a hydroureteronephrosis, you don't know what you're dealing with. Are you dealing with a reflux? You could have a primary megaureter. So then how do you counsel the parents? Because you don't exactly know. You're saying there might be a slight obstruction, there might be reflux, but we don't know.
Oh no, the point wasn't the VCUG. I think we have a diagnosis, it's good. The point is whether you then continue to investigate once you found low-grade VUR or treat. Because in my book, then if you're 1 or a 2, you don't need anything else doing, but everyone will have a different opinion.
Dr. Chandra, you were with Dr. Stephen Koff for quite a long time. So what would have been your approach at Columbus?
Yeah, thank you, Dr. Ansari. So as was mentioned just before this, if there is something that is likely to be sinister, then we will chase further. And that is very unlikely with this grade of a low-grade reflux. So if there is a high degree of dilatation or any bladder changes on the ultrasound, those are the situations where we may intervene if there is a ureterocele or an obstructive megaureter. With this kind of a dilatation, the probability that is extremely low. So in Columbus, it will be like, if you are likely to intervene, then you investigate. Because another important thought that was given is, just before the baby is born, a mother being pregnant, we are extremely careful about subjecting to radiation. But suddenly in our mind, it completely changes soon after the baby is out. And in terms of the susceptibility to radiation impact, it is not very different for that baby. So we need to keep that also in mind when we design on our algorithm.
Yeah, correct. So this is the scan, Ashish.
It appears to be normal, sir. Because
Both are very well lit up kidneys.
Yes, sir. There is no area of photopenia in
straightforward. Yes. So what are the usual recommendations that you should go for the AUA? You heard all the experts.
Yes.
And one group said that even ultrasonography, you need not to go for even for VCUG. And the second may say, if you get a low grade reflux, like grade 1 or 2, maybe 2 by 3, Will you go for DMSA scan or not?
So the standard guidelines, like AUA guideline, they suggest to do a DMSA scan when the grade of reflux is 3, 4, and 5, that is dilating reflux. And second, if you are having a sign like there is an elevated serum creatinine is there, or the child is having, suppose, a renal ultrasound which is showing some cortical changes are there, or there is a scar, then those are the situation when we go for DMSA scans.
Okay. So, Dr. Sardar, what is your policy?
Well, I would agree with all the others. If you start investigating, you keep on investigating.
Yes.
I would have been able to manage this child without any risks, not doing anything at all, just following with ultrasound and informing the parents properly. If there are any symptoms, I would interfere and give antibiotic treatment. Then I would consider doing further investigation. Without any investigation, if the kidney is normal, no cortical abnormalities, there is a dilatation, we know that there is a chance of having reflux, but this reflux is not important unless there are symptoms, then we would follow the patient for symptoms. This is my personal approach would be to a patient that I'm in good touch with, that I can also communicate well. Otherwise, I mean, to be proper or formal and medical legally correct, you have to do everything. You do VCG. Once you have VCG and there is reflux, you need to get the DMSA. For this patient specifically, I didn't like the appearance of the kidney on the VCG. It looked a little bit small and dysplastic to me. I would specifically do the DMSA for this case because of the appearance. Otherwise, if there are no symptoms, low-grade reflux, there is hardly, and there are no cortical abnormalities on the ultrasound, there is hardly you can find on a DMSA. But again, we go ahead and do it because it's formal and it's part of the routine workup.
Okay. So, Dr. Anju, what will be your approach at Manchester?
Usually in grade 2 and 3 refluxes, we would do a DMSA scan. But I agree with the point that in a low grade reflux we don't really expect much of scarring. So what do we gain by DMSA? That's something I'm sure we can sort of think about. But at the moment, we do get a DMSA done.
So, Dr. Mary, will you differ?
For me, only 3 to 5. 1 and 2, I probably stop prophylaxis and not investigate further.
Okay. So, Dr. Mallikarjun, do you have different thoughts?
I have a basic issue here is if your investigation is not going to change your management, you as well not do it.
Perfect.
So, an ultrasound on a neonate with a dilated system where you realize that it is really not obstructive and it is not causing any renal deterioration. I think, hold on, what is the real jump to do? Let us think it is a grade 4 or grade 5 reflux.
Right.
How does it matter? Even let us think you have a non-functioning kidney here or you have a dysplastic kidney which has got very poor function. Are you going to sacrifice it at this point of time?
Yes.
No. So I think we should be tailoring the recommendations are okay.
Right.
Recommendations are for us to actually give us a path to choose the correct thing for that particular child.
Right.
I'm not going to do a DMSA straight away, even if it is a grade 4 at this age. I will be looking at the progress of the child and then subsequently deciding whenever it is appropriate. But I will do a DMSA. I'm not saying that I will never do a DMSA, but we will do it at an appropriate time.
Okay. So I take you to another debate, which is quite relevant in this context, especially where the reflux is diagnosed, this hydronephrosis is seen, which is asymptomatic, and you find reflux on screening of ultrasonography only. So Ashish, is there a different policy to skin a cat?
What we have discussed till now was a bottom-up approach, sir. There is another approach which is a top-down approach where we first do a DMSA scan, and if we find some abnormality, then we go and do a Whiting's hysterectomy.
So it is what we have the recommendation for American Academy of Pediatrics, that is called as a top-down approach, where you go first for DMSA scan.
Yes,
And then if that shows some abnormality, then you go for the conventional approach is this, the American Academy of Pediatrics 1999 guidelines. And what we are talking is the Sweden approach, described by Dr. Hansen group, that you go for DMSA scan if you suspect that there may be some abnormality found depending on the presentation of the baby, and if needed, because the VCUG has more in terms of this invasive procedure for not only for the baby as well as for the family also. So
was that described
yes,
for the
please, yes.
prenatal group or those presenting with a UTI? Because I'm not sure it's
Yes.
really relevant for a prenatally diagnosed patient.
Right. So what is the rationale for these two different approaches?
So the rationale behind using a top-down approach is that if you are, we are avoiding doing an invasive investigation in a child, and by that, if we are missing a reflex, we are missing a low-grade reflex by around 20 to 25%.
So Dr. Sadar, what policy do you follow? This is the what conventional one or this top-down?
Okay, first of all, as Marie-Claire said, this is not relevant for this case because this approach is only after febrile urinary tract infection. If the child has got febrile urinary tract infection, you can take two choices. You can go ahead and do the VCG, search for reflux, and do the MSA after that. This is a bottom-up approach. This is one approach. The other one is the top-down, the first DMSA. And you don't wait for a long time for the DMSA. You do it short after the patient is treated. And if there is some loss of uptake, then this is a sign of pyelonephritis. That does not mean that there's a scar formation. It just means that this kidney is affected by the infection. So there is a risk of having reflux in that specific patient group, and you do VCG. That approach is very rational, especially after febrile urinary tract infections. By doing that, if the kidney is not affected, you may omit a number of VCUGs, and that has been shown in several studies. So this is what we like to do if the patient has got urinary tract infection, febrile urinary tract infection, and there are no findings on the ultrasound. We would first do the DMSA. But if there are findings on the ultrasound, then like dilated ureter and vice versa, we would do a VCG then the MSA.
Okay, so Dr. Prasanna, I'm sorry coming too late. Please, your thoughts about this, because it's a very favorite topic to you also.
Yes, sir. The other point is when there is dilatation on ultrasound, then I don't think top-down approach is the way to go. It always has to be bottoms up. Apart from the fact that we are evaluating a case which was prenatally identified.
Right.
So with any dilatation, it is always the bottom-up approach.
Okay. So one point what Dr. Sardar said, because that may not be apt for this case unless this is a presenting with documented UTI, presented with febrile UTI, then you may take the two different approaches. So we also have Dr. Ishtiaq from Bangladesh. Dr. Ishtiaq, what is your policy? If you can unmute.
Good evening, sir.
Good evening.
And hi to everyone. Yeah, it has been clearly said by Dr. Sardar Tegul that for something we need to do for medical legal and something case by case. So in this case, I would have followed the baby only with ultrasonogram, and if symptoms arises with urine analysis and culture, and then go for other investigations, not right away. Okay. Even there is no symptom, I wouldn't prefer any antibiotic prophylaxis.
Okay, thank you. So that we will discuss in our treatment part. So
but one thing, just a moment. Yeah. So I think our approach will also change if it is a single kidney.
Yes.
Congenitally single kidney.
Mm-hmm. Right.
So we can discuss if time permits about reflux in a single kidney.
So what advice you will give, Ashish, to the parents?
So we have to discuss with the parent, and we have to say how much accessible that parents and kid is to the healthcare system. If the kid is well accessible to the healthcare system, then we can keep the child on a follow-up. Else we will, as per our institute policy, we will start low-dose continuous antibiotic prophylaxis. In those cases, we find that the kid or the baby might not reach or might not get the correct health facility immediately, sir.
So what is wrong in close surveillance? Why do you want
Sir,
to give this reflux has been diagnosed on screening only? Otherwise, there is no history of this febrile UTI or UTI as well.
sir, we are a tertiary care center, and many of the time what we find is that we get rural patients also. So quite often they have a febrile illness and they are not being diagnosed. They are only being treated, and they only report to us when they have 3 or 4 febrile UTI episodes.
Yes. So we can
That is the reason, sir.
further. What you will recommend? Close surveillance, I think, or continuous antibiotic prophylaxis?
Okay. Well, in newborn refluxes, the risk of having breakthrough UTI has been investigated in the literature. So you need to look at different factors that may play a role in having breakthrough urinary tract infections. If you compare antenatally diagnosed asymptomatic group with the symptomatic group, it has been shown that actually the symptomatic group does a bit worse than the asymptomatic group in terms of having breakthrough infections. However, in the asymptomatic group, the risk of having high-grade bilateral reflux is much higher compared to the other group because they are picked up prenatally, and most often what you pick up prenatally is high-grade reflux. And what is really very well outlined in the literature is that high-grade refluxes have higher chance of having breakthrough urinary tract infections. And also girls do have higher chance of having breakthrough urinary tract infections. In my policy, personal policy, if you look at the guidelines, ESPU guidelines, it will say no matter what the age, reflux grade, or whatever it is, you give antibiotic prophylaxis in the first year of age. Because this is the safe approach, and you have to be medical legally correct also when you make a statement in the guidelines. But you can tailor that statement, and I would personally omit continuous antibiotic prophylaxis in low-grade reflux patients presented without any symptoms, prenatally diagnosed patients, and especially in boys, especially if they're circumcised. If they are girls, I'm a bit hesitant to omit continuous antibiotic prophylaxis. And whenever I omit continuous antibiotic prophylaxis, I discuss with the parents extensively about the risk of having urinary tract infection, etc., and inform them about the symptoms, and they should apply to a healthcare center as soon as they see those symptoms and be treated. Otherwise, I don't omit continuous antibiotic prophylaxis in any patient.
Dr. Anju, will you have the same policy?
Absolutely. I think Sardar has put it very clearly, and I completely agree with that policy. Yeah.
Okay. Dr. Mary, will you differ?
No, I agree. I'd have a conversation with the parents. The only thing I was going to add, and I think you're going to bring it up on one of your slides, is that the only randomized control trial in the literature comparing prophylaxis versus non-prophylaxis in the prenatally diagnosed asymptomatic group is the PREDICT trial. Now, the PREDICT trial compared no prophylaxis versus prophylaxis in only grade 3 to 5 VUR. This one we think is 2 to 3, whatever you want to call it. But their outcome was that both groups ended up getting a febrile UTI, 21% in those on prophylaxis, 36% in those without prophylaxis. The only difference was that the ones on prophylaxis got it a month later, and they were more likely to get resistant organisms, which were harder to treat. And the outcome of that trial was that exactly what Serdar said, boys probably don't need prophylaxis even with high grade. In their trial, circumcision didn't make a difference, but they said girls were at higher risk of UTI, and they would recommend prophylaxis in girls up to 1 year. So therefore, in this particular case, I would have a chat with the parents and I would tell them what this trial showed. In their case, it's a grade 2. So I think we need to play it on how anxious the family is. Some families will want to have the prophylaxis. Others will be, well, we'll wait and see. Thank you for the information. We'll watch for signs of UTI. So I think there's no right or wrong answer in this case, really.
So Dr. Prasanna, you too have many cases, small babies with antenatally diagnosed nephrosis and reflux. And if you had the similar baby in your clinic, what will be your approach in Indian circumstances? Will you give antibiotic or just follow this European policy?
Over the last 1.5 years, we've stopped giving antibiotics
Okay.
if we are reasonably sure that the child will come for follow-up. And so far seems to have worked well in this age group. Need to follow up for longer, sir.
Right. Dr. Bhatt, do you have different thoughts?
I think this antibiotic prophylaxis is to be started with the symptomatology only. We can
Yes.
wait and follow, or ultrasound we are following if there are any changes of scarring or the child is symptomatic. But if you are not very sure of this one, that the child it's far away in the periphery and they will not come for the follow-up, then one should go ahead with the prophylaxis.
Yes. Okay. So with this, we come to the conclusion of this, because we will be discussing more about the antibiotic prophylaxis and other modes of treatment in subsequent cases. So Dr. Amit, are you ready? Dr. Ashish, thank you very much for this case.
Yes, sir. Thank you so much, sir.
Amit, are you
Sorry.
ready? So
Yes,
we'll
Can I
move-
make a
yes.
comment?
Oh, yes.
Dr. Ansari,
Yes.
about this? I mean, the newborn reflux, the risk of having breakthrough UTI. There are many factors in playing role, but there is one factor that we cannot really quantify or classify, is the infantile lower urinary tract dysfunction.
Yes.
We have no way of really a reliable way of diagnosing that or analyzing that. The only one that you can do is the bladder capacity and what the post-void residual urine is. There are a few studies which looked at this, and having any form of lower urinary tract dysfunction, which is mainly represented by having residual volumes after urination, has been shown to be a major risk factor for breakthrough UTI. And if you're doing ultrasound, and if you're able to look at the post-void residual urine, and if you see quite a amount of it, then this is a very good sign or indication for you to put the patient on antibiotic prophylaxis, no matter what the grade of reflux is.
Correct.
Who said anything about?
I fully agree with you, because if you're suspecting some infantile bladder dysfunction, there may be other associated pointers in that baby also. Maybe that, yes, maybe that it may be a bilateral involvement, or there may be some thickness of the bladder wall also. And yes, and even they may present early with the recurrent UTIs also. And you may find sometimes a surprising scar in the kidney. So these are 4 or 5 points which may give you that might be having some lower tract dysfunctions also.
Okay.
So can we move to the second case? Amit, are you ready?
Yes, sir. Yes, sir.
So this is now we go to the postnatal management. This is 6-month-old male baby. Mother gave the history of a recurrent fever, and the last fever recorded was in between 99 to 100 degree Fahrenheit. And the urine analysis also showed WBCs in the range of 4 to 5 pascals. And UTI was documented twice in last 6 months also.
Okay, sir. So this is a 6-month-old baby with febrile UTI. So in this patient, sir, I'll like to examine the patient and see, as is a male baby, sir, I'll ask the history of any like patient urinary stream, how it is, and further, if the baby is sick, like in how the patient presents to us. So we'll do the further blood investigations and manage the baby accordingly. Yes,
So
sir.
that will, I think, fulfill your this requirement. Child on examination, child had a dull look, but mother
Okay, sir.
told that he had a good stream, did not
Okay,
apply
sir.
force, yes, and doesn't scream at the time of urination also. And the local examination, the vitals, prepuce, everything, both the testes were descended, and the baby was uncircumcised.
Okay.
So we'll like to further investigate the baby, sir. As the baby is sick looking, at least we'll get one ultrasonography of the patient. Renal blood ultrasound. We'll get it, sir.
Assuming the local examination, including the spine as well, they were normal.
Okay. Okay,
So
sir.
you want ultrasonography.
Ji, sir.
So this is the
Yes.
ultrasonography.
Okay, sir. In this, only one single image is shown of the, like it's mentioned, left kidney, sir. So parenchymal thickness appears to be good, and there is SFU grade 2 hydronephrosis is seen. And sir, like this report only we have to trust because other images are not there, sir. In it's mentioned like ureters are not dilated and the right kidney is normal with the bladder was partially filled, sir.
So what more do you want?
Sir, we'll like to first stabilize the baby, sir. If the baby is like sick looking, so first we'll give the antibiotics and stabilize the patient, and then we'll further investigate the baby. Maybe to repeat one ultrasonography to ask the radiologist to look for the retrovesical ureters, sir.
Okay, he was very well managed by a pediatrician. Febrile
Okay,
episodes managed with the IV antibiotics, antipyretics. Baby showed
Okay,
good
sir.
clinical response also. So you would like to
Right.
repeat a good ultrasonology. You want some more information also. So
Yes,
this
sir.
is the
Yes, sir.
algorithm. Yes.
Yes, sir. In this algorithm, it's sir, whenever the patient presented to us with a febrile UTI, it's and renal bladder ultrasound shows any abnormality, we first will stabilize the baby and further evaluate for the reflux in the baby, sir. If there is we have ruled out the lower unit tract, sir.
So here is the ultrasonography. Yes. Repeat ultrasonography.
Yes, sir. Sir, this most of the times we'll get, sir, this kind of picture when repeat ultrasonography shows the retrovesical ureter to be dilated. So in this case also it is like in the repeat ultrasound, it is showing the left retrovesical ureter dilated with the other kidney being normal, sir. Yes, sir.
So what are the recommendations for this workup? The kids who are presented with febrile UTI and
Sir, according to ESPU in EUA guidelines 2023, it's always recommended to get children presented with febrile UTI with 0 to 2 years of age, it's better to get one voiding cystourethrogram, sir. So to further manage this patient, sir.
so these are these recommendations by ESPU. You want a VCUG depending on these guidelines.
Yes, sir.
So these are some pointers depending on you may order the next investigations. So we quickly go to the yes.
Okay, sir. In this voiding cystourethrogram, sir, I can see the bladder wall seems to be smooth and the anterior urethra is not shown, but the posterior urethra seems to be normal, sir. And left side, I can see there is dilated and tortuous ureter being around grade 4 reflux is there on the left side, sir.
And what is missing in this film?
So urethra is not seen, sir, properly in the anterior urethra is not seen.
But we believe that the urethra was also normal because the posterior urethra is not abnormally dilated. Yes.
Yes, sir.
So what should be the timing, ideal timing between the last UTI and ordering VCUG?
Sir, it's ideally like whenever the patient present with the acute febrile illness, so it's better to wait for at least 4 to 6 weeks so that the chances of acute pyelonephritis are minimized and the baby's urine is sterile. Then we'll go ahead with the VCUG, sir. So at least 4 to 6 weeks time should be given, sir.
Okay. Okay. And obviously now you will be asking, depending on the discussion, the last case also, you will need DMS scan also. So what should be the timing for the DMSA scan?
So DMSA scans, sir, like our protocols, sir, we'll delay it for at least 3 months, sir, so that if there is any acute pyelonephritis episode and that photopenic areas because of pyelonephritis is not there, and we can see if any scarring is there in the kidney, sir.
Is there a role of acute DMSA also in acute phase?
Yes, sir, it can be done, but But like our protocol is our institutional protocol is to go ahead with 3
So we
months.
will ask this point from experts. Let me come to the scan directly. So read it, then we will ask Dr. Sardar and other experts. Yes.
Okay.
Ansari, Dr. Ansari.
Yes, sir.
Amit.
Yes, sir.
Do you think the bladder capacity of the child was normal? Bladder is bigger than the normal one?
He's like 6 months old baby. As the contour of the bladder is smooth, sir. So I think maybe the film is magnified also, sir. Cannot comment on that, sir.
The same thing as Sardar
Okay.
earlier pointed out.
Yes, sir.
The largest bladder, then what could we suspect other things in these patients?
But that is also true. The refluxing bladders are usually larger. Yes. Yes.
Or because they're larger, they reflux. We don't know.
That's the point.
So, because this reminds me of this, there is a old professor who was taking lecture on varicocele. More, he said those who are having varicocele, they have usually smaller families. And somebody stood from the audience, he said, I have also seen, it is also true, larger the varicocele, bigger the families.
Yeah.
So,
Well, I mean, this patient had big bladder. A good way of judging this would be if the cystography, when it's full, it's extending beyond the margins of the inner bony pelvis. It is most commonly a big bladder, and a high capacity bladder does not empty well in infants. And because they don't urinate completely, they have some sort of a interrupted voiding, and they don't empty well, especially when they have big bladders, and they have higher chance of having urinary tract infections. I think that's a good sign that needs to be taken into account in many patients. And for the TMSA, Dr. Ansari, I want to ask the audience if anybody would consider doing top-bottom approach. Start with a DMSA in this child. There's dilatation in the ureter and grade 2 dilatation in the kidney, febrile urinary tract infection. Would you consider doing a DMSA first and then do the VCUG later?
Yes, I think Dr. Prasanna will go with this approach.
But there is already a good sign that there's reflux in this patient. This approach is just to omit the possibility of VCUG in a group of patients who does not have reflux.
Yes,
that is. We know that there's already enough sign there that this patient has reflux. So for this patient group specifically, I wouldn't consider DMSA first. I would consider DMSA first if this patient hadn't had any dilatation or calyceal dilatation or hydronephrosis, but febrile urinary tract infection. Then you would consider doing DMSA, and if there are some photopenic areas, that is a sign of having pyelonephritis, and the underlying cause may be reflux, and you would do the VCUG later.
Correct. Dr. Mari, will you differ?
Sorry?
No, I was going to agree. It also depends a little bit. So different countries and different institutions have different traditions on VCUG. So for example, in London and I don't know what it is in the rest of the UK, but our radiologists will not do a VCUG after 1 year of age. For various reasons, parental anxiety, the catheter, they think the child won't pee around the catheter, etc., etc. So for me, if I've got this one is crying out loud to be a refluxer, right? If I have a baby, it's likely to be a reflux. It's a sitting duck for more infections, then I may as well just start with a cystogram because I've got a baby in front of me who can get a cystogram. Now, if it's a different child who present with a febrile UTI and they're 2.5 and it's not quite the age for a cystogram, then I might choose to do a top down. But I think in an infant, I would definitely start with a VCUG.
Dr. Anju, will you differ or you will have the same top down or top up?
No, from bottoms up. So do the VCUG first, like Sardar said. And I think, like Sardar mentioned, I think it's very important that we see the bladder, because many a times we look at the cystogram, we just look at the reflux and forget about the bladder. to actually, make a note that the bladder is bigger or the normal capacity is very, very important. And what we've done now is we actually ask our radiologists to measure the amount of fluid that they've put into the bladder. That gives us an idea of the capacity of the bladder as well. So our radiologists now routinely report 100 mils put in the bladder, so we know what is the capacity of the bladder. So I think that's important.
Yeah, I agree with that. And just sorry, one other point is that some of them do overfill, so you can't always judge the bladder on one I know we've only seen one picture in this case, one picture in the other case. It's so important to see the whole series, the bladder emptying, the drainage of the contrast at the end of the study. So, like Andrew said, it's really important to get as much information you can from that one study.
So, Dr. Takwani, you also get some these kids from remote areas also. You will advise, I believe you will advise both the tests together in the same prescription. Dr. Takwani? So, can we go to Dr. Malika Arjun? Can you take this question?
Yeah. No, I still believe that we wouldn't do a top-down approach in this particular case. So only time probably we do a DMSA before, as Dr. Sardar said, that if you're not sure that there was pyelonephritis and you want to prove that there is pyelonephritis and you see a photopenic areas. Otherwise, ultrasound, an anomaly in an ultrasound, I think we are doing the VCUG, standard VCUG first, not even the radionuclide VCUG, standard VCUG first, and then we go ahead.
Okay, Dr. Chandra, you will advise both the tests together, I believe.
In this particular child, another thing I was a little concerned is about the configuration of the pelvic junction. And also the calyces seem to be slightly disproportionately dilated.
Yes.
So I don't know, a little bit of a concern about the concomitant PUJ, whether it is secondary to the VUR or what. The pelvis also seems so blown up. So in this particular child, I may be tempted to do a DTPA just to confirm the drainage pattern, if I may be allowed to.
But you usually get many kings and curls with slightly higher grade of reflux 3 and above.
That's correct. We do get, but here that extent of the pelvis and the lower calyx dilatation seems to be a little more than what the ureters are talking of. I don't know. It's just a sneaky suspicion.
Okay, okay. Thank you. So this is the scan available. Amit, we come
Yes,
back
sir.
to the question. Yes.
Yes, sir. So this in the scan, we can see the well contours of both the kidney with the photopenic areas seen in the left kidney, sir, on the both the poles, upper and lower poles, sir. And it's being shown as it's 38% of the differential function of the left kidney, sir. So is considering it as 3 months, so contour, it feels like scarring of the kidney, sir, in the left kidney.
Yes, please. Yes. So how will you manage now?
Sir, if we'll see the risk stratification of this child, he is having a high grade reflux and being age less than 1 year and is uncircumcised male and
Please, RD, please unmute yourself. Yes, yes, go ahead. Amit, you are unmute. You need not to unmute.
Oh, sorry, sir. I was I was
There
muted,
was
sir.
some other yes.
Yes, sir. So, sir, I'll see that he's a patient with according to the risk stratification. Some disturbance is there, sir, I think. This risk stratification, sir, it's a high-grade reflux with age of the kid being less than 1 year, and he's uncircumscribed male with the recurrent infection and scarring of the kidney. He's comes under the So if risk stratification, it's more risk, and we'll start with the antibiotic prophylaxis in this patient, sir.
You will give antibiotic prophylaxis.
Prophylaxis, yes, sir.
So I start with Dr. Mari. What will be your approach depending on this risk stratification?
Yeah, I agree. I think my tendency is to start with prophylaxis, see what the DMSA shows. we have published, and others have as well, that if you have scarring on the MSA in itself as an independent risk factor for further febrile UTI. So I have a chat about this with the family. And then we'll go from there. I mean, definitely if they have even one breakthrough, I'll recommend intervention. I don't think the evidence at the moment backs up intervention without symptoms, but this child's already had urosepsis. And then my recommendation would be circumcision and deflux injection under the first sitting if we were to do a procedure.
Okay, so Dr. Anju, before I go to Dr. Sardar, and he will be tempted for endoscopy also. Dr. Anju, what are your thoughts about the management?
Yeah, my management was the same as Mary's. So initially, all children, especially this one as well, with the UTI presentation with UTI, start on antibiotic prophylaxis, and any further sign of infection, definitely I will also do a circumcision. And because I'm taking the child for anesthetic, I always offer them endoscopic correction of reflux in the same sitting as well.
So, Dr. Sardar, the concern so far is this. Your thoughts?
Okay, well, normally we would give antibiotic prophylaxis to those patients, and in case of breakthrough infection, we would consider doing some sort of intervention. Mostly, if the child is still younger than 1 year of age, we would consider doing endoscopic treatment. There is also another option to do endoscopic treatment now, and this has been studied by the Gothenburg group, and they looked at high-grade refluxes, and there were 2 arms. It was a randomized controlled trial where they looked at endoscopic treatment versus antibiotic prophylaxis. And it's been shown that endoscopic treatment is slightly better in terms of having breakthrough infections than the other group. And however, the chance of having complete resolution after endoscopic treatment was less than 30%. So they would still need some other intervention later, some other workup and intervention. So doing endoscopic treatment I don't think it's got a role before we start antibiotic prophylaxis. It may have a role if the patient has a breakthrough infection under the antibiotic prophylaxis.
So, as told by the experts, so we all agree that antibiotic prophylaxis has to be executed, and these are the recommendations by AUA panel, consensus panel, that there are 2 groups. What they have said it clearly. Can you read, Amit, about
Yes, sir. Sir, according to AUA, according to AUA 2017 sir, guidelines, if the child is less than 1 year of age, and if the patient is not having any history of febrile UTI and is having a grade 3 to 5 reflux, so it's continued antibiotic prophylaxis should be recommended, sir, is recommended, sir.
So the child comes in this group, in this now. A continuous antibiotic prophylaxis with a history of febrile UTI.
UTI, yes, sir. No matter whatever the grade is, if the patient is having febrile UTI in less than 1 year, we should recommend the continued antibiotic prophylaxis, sir.
So before we leave you,
yes, sir.
What is the rationale of antibiotic prophylaxis? Is it really effective?
Sir, it's seen that antibiotic prophylaxis, it has a higher resolution, higher spontaneous resolution is there in children. So we can, by that time, we can start with antibiotic prophylaxis, and it's seen that sterile urine is benign, and if patient is having like less breakthrough UTI, so with the continued antibiotic prophylaxis, like some studies do favor this. Like one is Swedish reflux study, sir, in which there was 203 patients were studied, and which showed that patient on continued antibiotic prophylaxis, there was the patient who was not on continued antibiotic prophylaxis, there was difference of around 35%. And in the patient, the biggest trial of this is like a river trial in which 607 patients were taken. And on the patient which were on trimethoprim sulfamethoxazole, it was seen that the patient was prevented with like recurrent UTI by almost 50%, sir. But in those patients, yes, sir. And in this, sir, like primary outcome was primary prevention of reflux, and secondary being the renal scarring and treatment failure, sir.
So river trial demonstrated that prophylaxis reduced the risk of recurrence by 50%.
जी sir.
Although this did not affect the occurrence of knee scars.
Yes.
Okay. And
Yes, sir.
correct. And
Yes,
the
sir.
two highlights were this, what you're telling. Those index cases who
Wisdom.
presented with fever, and there was a kid suffering with bladder bowel
About
dysfunction.
dysfunction.
So,
Yes,
so
sir.
for the sake of this, we can also give this Australian study, prevent study, that also showed a difference of 6%. So
Yes,
this
sir.
may benefit the PGs also. Yes. So we have this. So these are some of the scarring, and the only adverse effect of this and antibiotic prophylaxis was resistance to antibiotics.
Antibiotic.
And in prophylaxis group, it was 63, and in placebo group, it was 19%. So
Yes,
the
sir.
question is, once the antibiotic prophylaxis has been started, parents will definitely ask how long the baby is going to continue antibiotic prophylaxis.
Sir, usually it's seen that there is a 20% resolution rate per year, sir. So, and it is recommended that it is given for 5 years. And another study which showed that if after 5 years there will be less chances of scarring will be there. The further new scars will be less, sir, after 5 years of antibiotic prophylaxis.
Antibiotic prophylaxis.
Yes,
So we go with Dr. Mary. What is your policy once you start continuous?
Yeah, I
How
mean,
do you, yes,
this
monitor?
is an excellent question, and I trawled through the literature recently because I wrote a paper about it. And actually, if you look at the good quality studies in the literature, pretty much all of them, including the PREDICT trial, including many other studies, quote an incidence of new scarring of 18 or 19%. And it's quite an interesting number. It's always 18, 19%. It's very similar. And some of the studies actually said that the incidence of new scarring was irrespective of whether or not these patients had breakthrough febrile UTIs. So I think one of the important counseling we need to give our patients is whatever you do, however good your reimplant is, however good your prophylaxis is, unfortunately, they still have an 18 to 19, one in 5 of them are going to get new scarring. I'm not sure which this 5-year study of prophylaxis is. I haven't come across it, but I don't think 5 years of prophylaxis is foolproof to prevent you having new scars. Secondly, again, in the Western, like in London, I don't think you're ever going to get a patient who's going to be on prophylaxis for 5 years. So the way I look at it is, again, look at your patient rather than kind of the general thought process. And looking at my patients, first of all, do they have renal scarring? So we know renal scarring is an increased incidence of breakthrough UTIs. Those without scarring, again, we've published, others have published that their incidence of UTI is actually quite low, and we stopped their prophylaxis at 1 year. We've done at least a 5-year follow-up now of those who've stopped prophylaxis, even those presenting with a UTI, and not a single one's had a breakthrough UTI after 1 year. So I think without renal scarring, you can presume that there's a high incidence of reflux resolution over the first couple of years. Now, the tricky bit is those of them who are scarred on prophylaxis. As we've said previously, with me, they get one chance, like one breakthrough, they're getting a procedure, and then after the procedure, I usually will stop their prophylaxis. So then it leaves you a minority of those who haven't had a breakthrough and are still on prophylaxis. We usually say until toilet trained, which can happen at any age. So I normally try and keep them till about 2, but it's variable. But I don't think I have any patients who stay on it till 5 for sure. I think it's an individual patient basis.
Yes, before going to Dr. Sardar, Dr. Anju, your policy, because this is a very pertinent question. Most of the family, they ask, how long you will continue, doctor?
And yeah, it's the most difficult one. I think the way I see it is that the first 2 years is when kidney is more susceptible to forming renal scars. So I definitely put them on prophylaxis for the first 2 years. And after that, yeah, potty training. Once they're potty trained, then it can be stopped. And I usually tell them that when they're in the process of potty training, it's better not to change things. So once they're potty trained, then I usually stop it in girls and boys. Yes.
Okay. So, Dr. Sardar, now your turn.
Okay, of course, we don't want to give antibiotic prophylaxis too long. There are so many good reasons for this. And we know that there are problems with antibiotic prophylaxis, antibiotic resistance, and there are some other issues related to long use of antibiotics, which are becoming more evident in many different studies. So we want to avoid antibiotic prophylaxis as much as possible. So we need to have a good indication to continue antibiotic prophylaxis in children getting older. Why do we give antibiotic prophylaxis? To prevent urinary tract infection. Okay, what causes infection? Most often in children, what causes infection is not the reflux itself, but most often the post-void residual urine or some sort of a bladder dysfunction. So we need to make sure that the patient does not have bladder dysfunction or any risk of having bladder dysfunction until we stop, before we stop antibiotic prophylaxis. So for my consideration, I would consider doing that after toilet training, and I'm sure that the patient does not have any significant sign for lower urinary tract dysfunction, then I would stop antibiotic prophylaxis. So because there wouldn't be any need for antibiotics to stop urinary tract infections in those children, because the main reason in children to cause urinary tract infection, in my understanding, is the lower urinary tract dysfunction. This is one. The second one is the presence of renal scars. Of the studies you mentioned about antibiotic prophylaxis, you need to look at the patient groups, and each study has different patient groups in terms of scar formations. For instance, the Swedish reflux trial has got the worst patient group to start with because they all had, the population had an average of 60% renal scar formation already took place in those kidneys. And you may have seen that those patients who were not on antibiotic prophylaxis did have more scars in the follow-up compared to the ones under antibiotic prophylaxis. This was not the same in other studies because the patients in those studies were not that scarred. They didn't have as much scarred kidneys as they had started with. And as Marie-Claire said, no matter what you do, you still have like 20% scar formation. But if you look at those patients who form scars, they are mostly the patients who already have scars. So I would consider giving antibiotic prophylaxis to those patients who already have scars and who may have a chance of having lower urinary tract dysfunction.
Thank you. Thank you, Dr. Sardar. And let me ask this question from the Indian panelist also. So, Dr. Prasanna, in Indian circumstances, how long you will continue to antibiotic? And when do you think that now the child is doing well, I should take conscious decision to stop medicine?
So I think we need to categorize them into high risk and low risk, though they are not yet toilet trained. So it depends upon whether it is unilateral, bilateral, the degree of reflux, whether the child is circumcised or not, presence, absence of constipation. And I guess soon as we get control on all of these things, we should stop the antibiotics. So in my practice, it should be anywhere between 4 to 6 months. If possible, circumcise the child, make sure the child is not constipated. And then I think we should stop that antibiotic and see what happens. More often than not, because of a busy outpatient practice, I mean, we don't evaluate them in detail. We don't take all these detailed histories and then, just put them on antibiotics. I think that definitely needs to change. We should not be giving antibiotics to these kids more than 3 to 6 months. Soon as we figured out what's happening and we've got control, we should stop.
So, Dr. Chandra, will you differ?
Yeah, thank you, Dr. Ansari. I concur with that because with the second visit, we kind of get an idea of how this baby is going to behave. And based on that, I'm more inclined towards reducing the duration of antibiotic. And if somebody tends to be worsening, there may be a role in a more aggressive intervention than just continuing prophylaxis.
Right. Okay, Dr. Mallikarjun, do you have the same thoughts or do you differ?
I think he messaged telling he's leaving.
Okay. So you must be busy. So, okay. So another important question is that many of the clinicians, they do not use single antibiotic. They have double antibiotics alternating with each other. Some have triple antibiotic policy. So what is your policy, Dr. Sardar? You use the same antibiotic if it is needed for years together? or you keep changing in between?
I like to use two antibiotics, one of the two. One is the trimethoprim, the other one is the nitrofurantoin. The reason why we like to use those is that they are more concentrated in urine. They are not excreted in feces like the sulfonamides, but they are mainly excreted in urine. And then actually you have a minimum inhibitor concentration of those antibiotics in the urine. So whenever the bacteria comes into the bladder, they will be killed by these concentrations of either antibiotics. I don't see a good reasoning of using different antibiotics. I've not seen any good data which proves that multiple antibiotics are better than a single one. So I don't use that. But I use one of the two, either trimethoprim sulfamethoxazole or nitrofurantoin. The children may have some difficulty in getting nitrofurantoin depending on the pharmacokinetics. Then I would use the trimethoprim.
Suppose we discuss this and we give the treatment options to the family. And instead of going for this long-term antibiotic prophylaxis, or somehow if the family or the baby is not compliant to the antibiotic prophylaxis, will you consider endoscopic management?
You're asking me?
Yes.
Yeah.
Yes.
I think endoscopic treatment is a good alternative to continuous antibiotic prophylaxis, especially for low grades of reflux. For high grades of reflux, I think reimplantation is better than endoscopic treatment.
So, Dr. Mary, will you differ?
So was the question, if they don't want prophylaxis, would I do endoscopic?
Yes. If the baby is not compliant, family is not going for long-term antibiotic prophylaxis, they want an alternative option for this.
I think, again, I'd have a chat with the family about the pros and cons of either doing nothing, because like we said, there's a good chance that they won't get an infection anyway, or just doing a circumcision, or doing both, and the risks, because although endoscopic injection straightforward, it's not without its risks. But yes, I would consider it, and if we decide that it's beneficial for the child, I probably would. Differing to Serdar, I would definitely not do anything for low grade, not even prophylaxis if they don't want it. So I'd only do endoscopic injection for the high grade. And speaking of success rates of high grade, again, we recently looked at our outcomes for endoscopic injection in only grade 4 and 5, so just the high grades, even in infancy. And we had a pretty good success rate. I mean, it was 84% with one injection in simplex systems and 99% if they have a second injection. And it was just a bit lower in duplex systems, so 80% with one injection. Pretty good with 2 injections, and a couple of them needed reimplants. But I think endoscopic injection done properly works relatively well, and it's so minimally invasive. So I would start with that.
So, Dr. Anju, I just asked, there are 2 techniques which are commonly done, is sting and the hit. And they were quite popular in UK at one time. So what do you prefer, to go for the sting, or you usually go for the hit?
So I think I normally go for the sting one. So inject from below, and then really I see the configuration of how it looks like. Are the walls nicely coapted or not? And if they're not, I sometimes do a hit at the same time. But really depends on how the appearance of the orifice is after doing the sting. Firstly, I do the subureteric injection.
Okay. Dr. Sardar, you will take for sting or you will take for hit?
I don't like injecting to high-grade reflux as much. And it depends on how the ureter's hydrodistending. You can only do hit if the ureter is hydrodistended. And I want to do hit procedure, sting procedure, endoscopic treatment for large gaping orifices. I would certainly do hit, double hit, but most often I don't like to do injection to those ureters. I prefer to do reimplantation. Our experience is that we have a success rate of nearly 75% with endoscopic treatment to those patients. But for us to be able to judge whether we are successful or not, we have to do VCG to all of those children. And in about 25, we have to do another injection and another VCG. That looks minimal invasive, but in the long run, many VCGs, it is not that minimal invasive. Whereas with the reimplant, it is quite straightforward. It's 2-day hospital stay, and we don't do VCGs, and the success rate is almost 100%.
Okay, Dr. Mary? Yes. What do you prefer?
Yeah, 2 points. Just further to the follow-up of endoscopic treatment. I mean, if they're well without prophylaxis, why repeat the VCUG? So we don't repeat the VCUG. But in terms of technique, yeah, I agree. I would hydrodistend. So Andy Kirsch described the hydrodistension grading system. So 0, 1, 2, 3. If there are 2 or a 3, you can get your needle nicely into the orifice. Then it kind of is asking for a hit. And I would combine a hit and a sting, which, like I say, have a relatively good success rate. If your hydrodistension is lower, a 1, maybe a 2, sometimes you can only do a sting. So I do whatever I think is going to give me a good coaption, like others have said.
Right. So these are the various classifications what Dr. Mary has mentioned. And coming to the success, so there are many factors which depend. Can you enumerate, Amit, quickly?
Yes, sir. These are the viewer grades, sir, and the technique of injection, surgeon's experience, and the aspect of the mountain. And the patient is having bowel bladder dysfunction concomitantly, and what the radiological feature like ureteral diameter ratio, sir, more than 2.24.
Okay. So these are the success rate from grade 1 to
grade 5, sir.
Grade 5. Yes. So we can quickly move to the next case, and the aggregate rate is 85%. And we have to skip some of the slides also. So we stop discussion in this case. So we move to the third case. Is Dr. Amir ready?
Yes, sir. Ready, sir.
Yes, we can discuss circumcision. What is the role of circumcision in cases of the reflux? Yes.
Sir, if the child is like according to AUA guidelines, sir, that child of circumcision is the option should be given to the patient. Like it should be an informed consent with the patient parents that circumcision chances of UTI will be less with the circumcision. But there is insufficient data, sir, to say how much it decreases the risk, and so that patient it should be an informed decision with the parents, sir.
Okay. So, Dr. Mary, what is your policy? In Europe, it is not very popular.
Yeah, like I said previously, we would offer it in high-grade reflux, especially if we're gonna do an intervention. But I have to say, I was in another panel recently, and there was a publication a couple of years ago from Tony Curry's group, and it was quite an interesting study. So they gave babies steroid cream for the foreskin to retract, patients with reflux. And they followed up the incidence of UTI in those with non-retractile versus those with retractile foreskin having used steroid cream. And the incidence of UTI was higher in those with non-retractile foreskin, but the incidence of UTI in those with a retractile foreskin was the same as those who are circumcised. So there is a body of evidence that suggests that maybe if you have a fully retractile foreskin, it's the same as circumcision. So in families who don't want a circumcision, you could certainly offer them some steroid cream to encourage retraction. But I still offer a circumcision if they want it.
Dr. Anju, will you offer circumcision in high-grade reflux or high-risk cases?
Only if there is a breakthrough UTI and then you're sort of forced to intervene to do something. And then I will, as I said, I always combine circumcision with the endoscopic correction of reflux.
Dr. Sardar?
Well, this is not a really case in my situation because they all get circumcised. There is enough body of evidence saying that if the patient is circumcised, the risk of having pyelonephritis is certainly much less.
Yes.
And especially for those children with reflux, I think the numbers are, you need to circumcise 120 children to prevent one pyelonephritis in normal children. but 9 children with reflux to prevent pyelonephritis. So I think there is good evidence that circumcision is good for those children.
So, Dr. Priyank, what is this policy at SICKIT and in America?
Sir, I think at SICKIT, circumcision is something that is like offered even in the clinics, because as we know, 60% of men in America are circumcised. So circumcision is something that is actively promoted as a UTI preventing measure very early on, ideally in the first few weeks to months of life. But yes, along with the prophylaxis, I think circumcision is something in North America that is actively promoted.
Can be, yes, also. So we have some more questions. We can skip it, Hannah. So we can move on the third case now. So
Yes, sir.
yes, Amir, are you ready?
Yes, sir. So there is a 4-year-old toilet-trained girl present with recurrent febrile UTIs, having experienced 3 episodes in the past year. She has been experiencing right flank pain for the past 6 months, along with frequent dysuria and straining during micturition. Additionally, she has bowel symptoms characterized by hard, lumpy stools, contributing to Bristol type 2 and suggesting a possible constipation. Sir, next slide, sir.
Okay.
So on examination, the child has a height of 100 centimeter and weight of 16 kg. The external genitalia appears to be normal, and the back and spine examination were unremarkable.
So what more information do you want?
Sir, seeing the normal physical examination, I would like to go for urine routine examination.
You read routine examination. Let us see. So this is, yes.
It revealed a positive leukocyte esterase and nitrate test with WBC count in urine as high as 20 per high power field, and the urine culture sensitivity confirmed the presence of E. coli, indicating a urinary tract infection. The serum panels were within normal limit.
What are the recommendations for this workup in this scenario?
The EU 2023 guideline recommended a detailed evaluation for lower urinary tract dysfunction in all children, especially after toilet training. Additionally, the primary focus of initial treatment should always be managing lower urinary tract dysfunction, according to this guideline.
Awesome. So what more tests do you want in this child?
I would like to recommend renal bladder ultrasound.
So it is there.
Yes, sir. So according to these images provided, it reveals a SFU grade 2 hydroureteronephrosis of right kidney with right retrovesical ureter diameter of exceeding 7 mm diameter. The bladder wall thickness is given as 3 mm in partially filled state. And there is also an X-ray scout film of abdomen, which displays a diffuse dilatation of colon with appearance of opacity with contained internal mottled air. It is indicating of severe constipation.
Okay. So what are the pointers which are giving a different diagnosis, differential diagnosis?
First of all, uh, there is a great second hydroureteronephrosis. Secondly, there is the presence of constipation. So we are going for low urinary tract dysfunction, which may be causing this reflux, acute reflux.
Reflux may or may not be there, but so far the story is this that this child
Dysfunction is
having
there.
lower urinary tract
Yes,
dysfunction
dysfunction is there.
along with bowel symptoms also.
Yes, sir.
Yes, okay. So what more information or text you want now?
Since the child is having the symptoms like urgency and dysuria, we would like to go for bladder diary as well. So this is a 3-day bladder diary recorded over 3 days, showing a daytime frequency of 4 to 5 episodes per day, 1 void during sleep, and a functional voided volume of around 220 ml, with no episode of incontinence.
So what is the interval frequency?
Frequency is 4 to 5 episodes per day.
4 to
5. It is meant as
Per
per this
day.
diary. Yes, sir.
So it is normal or abnormal?
It is normal, sir.
It is normal. You are satisfied?
Yes, sir.
What more information should be there in the this bladder diary?
It should be the symptom like urgency, and it should be have been mentioned.
It
Urgency
is
and
not
the
given
frequency.
there.
Yes, sir.
Okay. So what more test do you want now?
As this child is displaying symptoms of the dysfunctional voiding, I would like to order EMG, Euroflow EMG.
Euroflowmetry along with
EMG, Euroflowmetry with
valvular
EMG.
EMG.
Yes, sir. This EMG with Euroflowmetry has demonstrated increased sphincteric activity during micturition with a mean flow rate of 12 ml per second. So showing highly contributing towards dysfunctional voiding.
So what is your differential diagnosis now?
So my differential diagnosis is right grade second VUR with bowel dysfunction.
So what is the next test you would like to order?
I would like to order the VCUG, voiding systolic
VCUG.
electrogram. Yes,
So
sir.
why did you take with this Euroflowmetry and EMG first? Why not the VCUG if you're suspecting reflux?
Sir, the first should be the VCUG itself. EMG should be followed by the VCUG. But the symptoms are highly indicative towards the dysfunctional voiding. So as to prove.
So that is less invasive as
compared to VCUG.
And so this is
So
the
this VCUG, this provided VCUG static films shows a smooth bladder wall with even contour and good capacity. The urethra appear dilated, forming a spinning top shape with widened proximal portion, and it is showing a narrow distal segment. There is also a significant VUR with contrast material, as it shows is refluxing from bladder into the dilated ureter, extending it up to the renal pelvis with marked ureteral and possible calyceal dilatation. So I would contribute it as a grade 4 VUR, right? Grade 4 VUR with spinning top urethra and dysfunction.
So the next test you would like to have scan?
Yes, a DMSA scan. So because it's our institutional protocol, so this DMSA scan shows normal kidney size, and there is no evidence of decreased uptake as in the kidneys. And as per this, the differential renal function is 44 for right and 56 for the left kidney. So no evidence of scar.
Okay. So before we go to the management now, because we are already, Dr. Sardar, would you, the sequence of investigation is right, or would you evaluate the child in a different way?
Well, I would do, we don't do VCUG in those children, we do video urodynamics. It is actually replacing VCUG, and we have a better understanding of the bladder dynamics. Other than that, we would do something similar. The DMSA is not routine because the child was having febrile urinary tract infections or not. If the patient does not have febrile urinary...
She had documented UTI.
Yeah, if the child does not have febrile urinary tract infection, we don't routinely do the MSA. And also, the same here, looking at the VCG, I had the feeling that this kidney, the refluxing kidney, seemed to be scarred kidney, whereas on the MSA, it looked quite normal. This was a bit surprising for me. But other than that, we would do the same, yeah. We would. Dr.
Anju, will you differ or the same protocol?
I would say that if you do have the Euroflow study first, then seeing that Euroflow, it's a good opportunity to sort of do the VCUG and urodynamics at the same time. So it's a good opportunity. But in normal practice, you end up doing the VCUG first, and then you get the Euroflow later on, and you then might have to do a separate urodynamics depending upon the findings for the lower urinary tract dysfunction.
So, Dr. Mary, You will have the same sequence of the investigations, or you will differ?
Just briefly, I'm going to need to run to clinic in about 5 minutes, but I'll answer this one. So I have a slightly different practice. So I wouldn't do invasive investigations from the outset. So I treat the very obvious bladder bowel dysfunction you have there. I would say, and just with ultrasound and bladder emptying, a plain X-ray, treat the bladder bowel dysfunction. Significant amount of them will improve and their UTIs will stop. And then even though I have a suspicion of secondary VUR, then what am I going to do about it? And if the kidneys look normal on ultrasound, then I might not even do the MSAs. Now, a subset of them, you might treat the bladder bowel dysfunction. They're not constipated. They stop their accidents and their frequency, and they're still getting febrile UTIs. Then I probably would investigate for reflux. I agree with Serdar. I think if you think there is still a bladder issue, then probably urodynamics are more useful than doing a cystogram on its own. If I'm not worried about the bladder, then we would get a MAC3 cystogram to avoid the catheter. And if there is reflux, then some studies suggest, and I think my experience would support that if you treat the reflux, it does help. In addition to the bladder bowel dysfunction, it does help their symptoms. But basically, I would leave the invasive investigations for later in my treatment protocol.
Okay. So, Dr. Chandra, will you differ?
Yeah, it's just that I would, as Professor Tekul mentioned, I would do a video aerodynamics instead of a VCUG to get comprehensive information. Apart from that, everything else would be the same.
Right. Thank you. So, coming to the management, because we have one more case after that.
Ansari.
Yes.
Yeah, I think with the bladder diary, one should have bowel diary also.
Yes.
True. Yeah.
Yes.
It was mentioned in that Bristol type 2 was.
Okay, correct. Yes, I agreed. So coming to the management, so these are the certain points and the policies and which need to be followed. And coming to the relevant question, what is the impact, Amir, what is the impact of bladder bowel dysfunction on vesicoureteric reflux?
Sir, considering our patient as a school-going female child with grade 4 VUR with severe constipation and recurrent UTI, so there is a study, it has been studied that in children who have been given antibiotic prophylaxis, that resolution of VUR was 31% in children with BBD as compared to 61% without bladder bowel dysfunction. And according to the risk stratification, it's a grade 4 VUR with bladder bowel dysfunction in school-going children in a female child. So, and yes, sir.
So there is an impact on the resolution of the VUR when the children are on antibiotic prophylaxis, as well as there is an impact of this BBD on management in terms of endoscopic, while this did not show any impact in terms of open surgery.
Open surgery.
Yes. So what intervention you will advise now?
I would like to go for urotherapy first, followed by other. So the urotherapy for this patient includes a behavioral modification with adequate fluid intake and timed voiding, with pharmacotherapy in choice, with continuous antibiotic prophylaxis, anticholinergics, and management of bladder bowel dysfunction through laxatives and bowel program, along with pelvic floor training. And if it doesn't work, then we will, if necessary, treatment will also include endoscopic or open surgery.
So, Dr. Bhatt, will you differ or you will go with the same lines? Forget about the endoscopy and open. We just have put them for the discussion. Yes. For urotherapy. You are unmute. Please unmute, sir.
Urotherapy is the first choice, and I think this is a big problem in our country, especially the rural area where they don't find proper toilet, and in that area, both bladder bowel problems are much more common than is reported in our incidents. And I think this.
Yes, I will ask other expert also. But if you go to the Webster dictionary, You saw the urotherapy is defined as the treatment of medical condition by taking urine.
No, that is
That is very pertinent. That is very pertinent in India also. You check Webster dictionary, you check Collins dictionary, in everywhere the definition is same. I do not know how does the chat GPT defines urotherapy.
no, that is for a common man, not for our medical persons and pediatric urologist.
Yes. Dr. Anju, how will you treat this? Babies with BBD with reflux.
Yes. I think one thing I have a strong objection, not objection, I would say strong reservation about is the term, use of the term BBD as a generic term and a urotherapy as a generic term. I think we need to specify what the problem of the child is. So we have to say this child has constipation, and then we need to ask the voiding history. Does the child void infrequently? Because many of the children, they do void infrequently. So in terms of urotherapy, then what we need to advise is that yes, firstly, it's very important they should void on a more regular basis. And secondly, we need to treat the constipation. And I think the specifics of these issues are very important rather than treating it generically as a BBD and saying they need urotherapy advice and management, bowel management.
So, Dr. Sardar, how effective is the bowel program in your practice?
Oh, it is very effective if you do it properly, if you form the patients properly, if they are followed up properly with good measures. We like to use symptom scoring and see if the patients are really improving. And bladder diaries are good, but they may be complicated because you need at least 2-3 day bladder diaries and they don't do it that well. We like to use symptom scoring to monitor the patient's improvement. And I think urotherapy is quite successful, but doesn't always stop reflux. And the presence of reflux mainly depends on the anatomic deficiency at the UVJ. It becomes more important with the co-occurrence of voiding dysfunction. If you have voiding dysfunction, you first treat it, but if the reflux does not go away, then there's an anatomic problem there which needs to be corrected surgically. So this is our approach. But we certainly believe that urotherapy is very efficient if you know it, if you do it properly.
Right. Dr. Chandra. Dr. Prasanna?
I'm sorry. Yeah.
Yes.
Yes. As you rightly mentioned, this bowel management has been real challenge, especially for patients who come from long distance who cannot follow up. So the success directly is related to that in terms of telephonically following them up and reinforcing them, because there's been a major behavioral change which has happened over years, which takes a lot of time and reinforcement to manage. And eager to learn any successful strategies which Professor Tegul was mentioning about that the program is successful.
Okay, correct. Dr. Prasanna, another topic very close to your heart.
I agree with Chandra. The most difficult thing is actually bowel management and the way we actually monitor it and make sure that whatever we have advised, the parents are able to follow.
Yes. So Priyank, coming back to sick kid, what is the role of nurse practitioner? Okay. Nurse in certain treatment in children, there is a more important role of a nurse practitioner than the clinician itself.
Yes, sir, absolutely. I agree with you. And actually, talking about BBD, PBD is something that a lot of centers in North America have typically dedicated nurse practitioners taking care of these patients, because it involves a lot of counseling, a lot of follow-up. Sometimes they do phone calls rather than bring the patient from home just to understand if they are doing what they have been told to. So even like at our institution for last 2 years now, we have one dedicated nurse, and now actually 3 of them who are caring for these kids with BBD, and as well as all the other lower urinary tract conditions like neurogenic bladder and PUVs. So as a surgeon, it is not always possible for us to keep track of these the medical aspects of the management of BUR, which are sometimes more important, if not as important, than the surgery itself, because we all know a lot of these patients will eventually end up having a natural resolution of the reflux, and until that time we need to make sure that the lower urinary tract is functionally it's not predisposing them to any more infections. So nurse practitioners are pivotal, and it's important for them to keep in touch with the patients, keep them updated about the progress, as well as maintain a good database. In fact, sometimes it's important for them to even form little groups. These patients can learn from each other. The children can actually look at some of the techniques that other children have used in order to improve their functionality. So nurse practitioners, I would say, are pivotal.
Oh, thank you so much. Thank you, Priyank. Very pertinent, relevant questions and points you raised. So we quickly move to the fourth case. This is a very short case. Yes. Do we have Dr. Kunj? Thank you, Dr. Amir.
Yes, sir. Yes, sir.
Thank you,
Okay,
sir.
thank you. Kunj. So
Yes, sir.
just go through the history first, quickly.
Sir, this is a 4-year-old girl with known case of bilateral grade 5 reflux, and she is on antibiotics since 1 year. But she is having a breakthrough urinary tract infection and 3 episodes in last 1 year. And she had no lower urinary tract symptoms and no bowel symptoms. There is no constipation, and Bristol stool type is 4. The avoiding cystourethrogram shows that bilateral grade 5 reflux and bladder capacity looks normal and contour is regular. And I cannot comment on posterior urethra. This is a static film.
But yes, we believe that
Yes, sir. Yes, sir.
some
Yes,
of
sir.
the
Bladder contour
was
is normal, sir. Yes.
So obviously you will ask the scan.
There is photopenic area in left kidney, upper pole and lower pole, and also in mid pole, and the function is 36% in left kidney, and split functions, relative functions.
So I quickly go through that. And this
The
was
man-
yes, 4-year-old girl with high
High-
bilateral 5 with breakthrough
urinary tract infection.
documented UTIs, multiple, and these
Yes.
are the VCUG, and this is the multiple photopenic scar.
Yes, sir.
That is
Left
almost
kidney.
badly ridden with this. Yes.
Yes.
So,
Sir, this is a
what will you advise?
Sir, this is a high grade reflux, bilateral high grade reflux, grade 5 reflux, and multiple breakthrough urinary tract infection. So I would like to go for surgical correction, sir, in this child.
Surgical. What surgical correction?
Sir, this is bilateral reflux. So I would prefer intravesical approach for ureteric reimplantation, bilateral ureteric reimplantation, sir. The procedures name are Cohen's trigonal या फिर or Ledbetter polytono approach, sir.
Okay. Dr. Anju, what you will advise?
Yeah, this is certainly a child who's we are looking at surgical correction. So both the options are there. We can again discuss it with parents. If they're keen on an endoscopic management or a more conservative management, then we can look at least one trial of endoscopic correction of reflux, though chances in bilateral grade 5 are very low, or we can straight away proceed to surgical correction as well. So we can do it either open or we can do it laparoscopic.
Dr. Sardar.
Yeah, I think this is high-grade reflux. It will eventually need a definitive correction, which in my understanding is a surgical recorrection or reimplant. But before we do this, we would like to do an investigation of the bladder function, not necessarily by urodynamics, but minimal invasive methods like uroflowmetry, if there's post-void residual urine or not, how the bladder is emptying, how the upper tract is emptying, because there may be a accompanying UPJ problem, which needs to be taken into consideration as well. If the bladder is well emptied, we would expect that the hydronephrosis will show some resolution. If it's still the same in the kidneys, we may consider that this patient may have a secondary UPJ, especially on the left side. All those things should be taken into consideration before we do the surgical correction. But eventual treatment would be surgical correction in our understanding too.
So I just give you a hypothetical question. What are the cases where you consider for diversion in form of ureterostomy or vesicostomy?
Well, those are the cases if there's a severe bladder problem and if the child is very young, below 1 year of age, if there are breakthrough infections, you cannot stop them by antibiotic prophylaxis. By any other means, you can consider doing a diversion till after the patient is old enough to do a proper reimplant. But for this age, we wouldn't consider that really, unless there is some significant bladder dysfunction.
Right. So, Dr. Malika Arjun, what for you will take this kid? For open or for laparoscopic or robotic?
He left, sir. He left.
Okay, he left. Dr. Chandra?
Yeah, thank you. I would go for a straightforward open coherence reimplant. Bladder capacity is normal, and I think that's the best shot that is possible. Having said that, I'll forewarn the parents, because of this high grade, what the renogram shows may be an understatement of the degree of dysplasia. So even if our reimplant is successful, child is likely to have borderline functions or may even show new photopenic areas in the scan.
Right. Dr. Bhatt?
Yeah, I think I have my concern about the UPJ, because VUJ you are going to correct, and especially on right side also there is a malrotation of the kidney also. So with the rotational deformity, there are more chances of having the UPJ obstruction. So both has to be followed up, and specifically as you have to see after how much post residual urine, and if the tract still remains after voiding, how much is the upper tract dilated? That is more concerned.
Okay.
Rest, I'll go for open reimplant.
So, Dr. Prasanna, you have robot, you have laparoscope, and you have open surgeon also. So what will be your approach?
I would prefer open because the ureters seem quite dilated.
Yes.
But one of the options is also to do a robotic one.
Robotic, in cases of bilateral extravesical?
Bilateral extravesical, yes.
Okay.
I think Dr. Ansari and Dr. Prasanna will go for robotic. And rest
So
are
even though for robotic, it has some different applications also, but there are definitely concerns at your what Dr. Bhatt has said, that he would like to evaluate the UPJ also. But first, reflux has to be fixed. Then on subsequent evaluation, then this drainage scan can be done to confirm that. Yes. Any other thought, Dr. Sardar?
No, thank you. I have to leave anyway.
So I think this was the last case. So, and thank you very much, Dr. Sardar, Dr. Anju.
Thank you.
And
Thank you for the
Dr. Mary,
invitation.
Yes.
and Dr. Bhatt, Dr. Chandra, Dr. Malika Arjun, Takwani, and Dr. Prasanna. Yes.
Thank you, everyone.
Thank you. Dr. Bhatt would like to say thank you so much.
Thank you. I would
A
like
great
to
meeting. Congratulations, Dr. Ansari. The cases were selected very well, and it was a very well structured discussion. Thank you.
Thank you very much. Dr. Anju?
I would like to express my gratitude to Sardar, Anju, and Mare. And especially they have made it so lively and informative and educative. Thank you.
I really appreciate the questions, because answers are very pointed toward the question.
Yes.
Thank you. Thank you, Dr. Anju. Dr. Sardar, thank you very much.
Thank you very much. Yeah.
Dr. Chandra, Dr. Prasanna.
Thank you.
Thank you.
Thank you.
I know you all were very busy on this weekend, but on request from the section and the USI, really grateful to you all for sparing time. We almost consumed for 2 hours. You kept you busy for almost 2 hours.
Bye-bye.
Bye, sir.
Have a great weekend.
Thank you.
Bye.